Okay, here we go. Hello. Welcome back to the 2022 Iowa Ideas Conference. This is the healthcare track, and I am Michael Chevy Castronova, editor of Iowa Ideas magazine and the business editor at the Gazette. In this panel, right here, right now, we're going to talk about the high cost of prescription drug prices for you, for me, for everyone. And it's a big topic, and we're going to get started, but two things first. First, I want to thank our track sponsor for the subject matter for this, the University of Iowa Hospitals and Clinics. And I believe we have a short message from UIHC that we could watch now.
Welcome to the Iowa Ideas Conference. I am Kimberly Hunter, Interim CEO and Interim Associate Vice President of the University of Iowa Hospitals and Clinics. The COVID pandemic brought about exceptional challenges, such as worker shortages and healthcare disparities that really have changed the way we view healthcare. However, it has also highlighted opportunities for innovation and improvement. For example, we have seen a move towards telehealth, which helps us provide better access to care for all Iowans. We know that healthcare excellence is achieved through innovation and collaboration. And that is why we are a proud sponsor of this conference, and we are excited to hear your big ideas on how we can come together to improve quality of life and quality of care in Iowa. On behalf of the University of Iowa Healthcare, we hope you enjoy the conversations, make some great new connections, and leave inspired to help us shape the future of healthcare. Thank you.
All right, and so now we want to introduce our expert panel, and they are from different aspects of healthcare industry. So I'm going to go around the screen, and as I see people, we will call on you. And if you tell me your name, your title, where you are, and just an executive summary of what you do. So first on my screen, Matt. Hi.
Thanks very much, Michael. I'm Matt Osterhaus. I'm a community and consultant pharmacist in Maquoketa, Iowa. I manage both a community pharmacy and a long-term care nursing home pharmacy here. I am a University of Iowa graduate from several decades ago and have been actively involved in putting community pharmacies together in networks, both in Iowa and across the country, to provide patient care services to the patients that we serve.
Thanks. Darlene, how are you this morning? This afternoon, sorry, your time this afternoon.
Thank you very much. Well, my name is Darlene Schmidt, and I graduated in 1966 from the University of Iowa Practical Nursing Program. And I'm still 57 years working full-time, taking care of people uninsured, underserved, and just a heart to take care of people in need. I'm the co-founder of Community Health Free Clinic here in Cedar Rapids, along with Dr. William Galbraith. And we serve anywhere from 5,000 to 8,000 individuals every year here, providing healthcare, eye care, dental, everything that they need, plus some social workers to help us with whatever patients are needing from housing. So that's what we do here, is take care of people in need.
Okay. Rob, you're next on my screen.
Hi, my name is Rob Nichols, and I am a community pharmacist in Waterloo, Iowa at Greenwood Pharmacy and Compounding Center. I am also an Iowa grad. I'm a 2017 Iowa grad, and I completed the community-based pharmacy residency here in Waterloo at Greenwood Pharmacy. And in my job, I am, in charge of researching and developing patient care services.
Okay, Andrea, how are you?
Hi, I'm good. My name is Andrea Sipe, and I work for the Iowa Insurance Division, the state's insurance regulatory agency. I am the Senior Healthcare Policy Specialist. This is a pretty new position for me. I was previously the Assistant Commissioner for about 5.5 years, but I'm looking forward to entering my new role where I'll be more focused on all aspects of healthcare, including helping implement the state's oversight of PBMs, working in all aspects of the Affordable Care Act, the Mental Health Parity Addictions Equity Act, all other federal and state laws relating to healthcare. I have worked for the division since February of 2016 in the state of Iowa since 2010. While I've worked for the state, I've helped the insurance division with our stopgap measure. But I also worked for Medicaid for quite a while and was the program director in charge of implementing the Medicaid expansion or Iowa Health and Wellness program. I am I guess right now, the only Iowa State alum on the panel. I have a master's degree from Spertus Institute in Chicago, Illinois, and a law degree from Hamline University in St. Paul. And I'm glad to be part of the panel today.
Thank you for being with us. Juliet.
Hi, Michael and everyone. I'm Juliet Kubanski. I am Deputy Director of the Program on Medicare Policy at KFF, or the Kaiser Family Foundation. We are not associated with Kaiser Permanente, the health insurance company. We are a national organization focusing on health issues. We serve as a nonpartisan source of information, analysis, polling, journalism on US and global healthcare issues. In my role at KFF, I focus on Medicare policy with a particular emphasis on prescription drug policy issues. And I've been at KFF for almost 20 years, focusing very closely on the Part D drug benefit program and related Medicare policy issues. So I'm really happy to be part of this discussion.
All right. Well, thank you all for being with us today. And those of you watching, I want to remind you, you can ask questions, you can raise your comments. You do that through the chat button at right down there at the bottom of your screen. Those will come through to me and we will talk about those. Please do not wait until the final 15 minutes of the panel. I know that's a habit, but don't do that. We're more likely to get to them if we can do that sooner. So now to our discussion. Bloomberg News reported in July that Americans spend more on prescription drugs, quote, than anyone else in the world. That's an average cost about $1,300 per person a year. Now, we know for some people it's a lot more and some people it isn't so much, but the United States, unlike other governments, historically has not directly regulated or negotiated with drug manufacturers over the cost of medicine. So pharma essentially can write whatever price tag it wishes, to be cynical about it. And quote, while private insurers and government programs pick up the biggest share of the bill, high drug costs are passed on to the public through your premiums, through taxes. This is a big, complicated topic, as we were discussing before we started. And I want to set the stage at first. So we're going to take this in pieces. So I want to start, Matt, Rob, you're probably the two best to speak to this. In a report in Iowa Ideas magazine back in 2019, we talked about this. Kate Greiner, the Iowa Pharmacy Association executive, vice president, CEO, made the point that pharmacists act as sort of a fact check on the system, part of the checks and balances to ensure that meds being prescribed don't interact in a bad way with other prescriptions. And again, we're going to start here and work our way up on all the pieces on this. So Matt, can you talk just a bit on what are the wide range of tasks the pharmacist does, frankly, that most of us don't see, because you're at the front line, right? So what do you do all day other than run a business?
So as a prescription order comes in for a patient in our practice, Michael, we are looking at not only the variables that surround that particular patient. So we want to know, what chronic conditions do they have? Do they have an acute condition? So we're looking at any order that comes in with an eye of, is this the right drug for this patient being dosed properly? So as the prescription gets processed, most of them begin on an electronic in Iowa, at least, an electronic venture from the physician's office and prescriber's office to us. And then we not only utilize software programs to look at potential drug-drug interactions, but also utilize our own clinical skills to look at what does that patient weigh? What other medications are they on? What is the right dose for this particular patient, depending on their age and the function of their kidneys? So the process isn't just boom, boom, an order comes in and then it goes out. There's steps along the way that not only involve our technical staff, our technicians that process the order, but the pharmacists looking at that with a careful eye to say, is this right for this patient? You know, and we talk about the cost of prescription drugs, but you know, the costliest prescription drug is one that's not right for the patient, or that the patient doesn't understand how to take or why they're taking it, because we can spend a lot of money on medications that are basically being wasted because they're not the right drug for that patient. And so, you know, a gatekeeper, I like to really think of the pharmacist as just part of that individual healthcare team that's working with frequently multiple prescribers who are sending different prescription orders to us to make sure that there is a common place where this is where the drug therapy is really evaluated, whether it's coming from the cardiologist or the family practice doctor or the dentist or the ophthalmologist, to say that this is what's right for this patient. So it's a you know, you do feel like a gatekeeper to a degree, but I like to think of us more as that team player that's the last stop between the patient and that the rest of that healthcare system that they've accessed.
So,
Yeah, Matt, I
Rob-
think,
Yeah, go ahead.
yeah, I like how you talk to us about being a part of the team, because that's how I view it too. You know, the gatekeeper is one way to, I guess, talk about it. But you know, there's many situations in the pharmacy to where, like you mentioned, there may be multiple providers that in their individual rights may be thinking that, hey, this is a medication that is going to be safe in treating this one thing. But when I look at a combination of medications together, for instance, if we think about the triple whammy, you have a couple on medication treating blood pressure, one treating pain, and one trying to get fluid off, that can lead to this hospital visit that might shut down somebody's kidneys. So we kind of are looking at these different combination medications, how your kidneys might affect it, how your liver might affect those drugs, and trying to ultimately end up with a safe outcome for that patient.
So again, because we are talking about costs here, Andrea, at the Iowa Insurance Division, how does what Matt and the people with the Iowa Pharma Association, what they charge for a drug, how much does that, and this is going to sound like a leading question, but how much does that actually affect when it comes out of, when it gets to the insurance part of the world, when I have to pay my premiums? How much does one relate to the other?
Well, certainly the cost of prescription drugs is calculated into what the overall premiums are, and premiums are based on, you know, basically healthcare utilization. So although the most costly healthcare benefit usually comes from hospitalizations, but prescription drug prices have gone up year after year after year. And the time that I've been with the insurance division, we've seen kind of a steady incline. So as we're seeing the overall cost of all of healthcare go up, that definitely raises the overall cost of premiums.
And so, Darlene, at clinics, how does that cost affect what you're doing? I mean, surely it must.
Well, all our donations come from our generous donations and for foundations and grants. So I hate to say this, but we don't look so much at the cost of that. I just know what
Sure.
the overall is. So patient comes in with that script from the dentist for Pen VK. We buy stock bottles, we just fill it. So our focus here is nothing more than following the doctor's orders. The pharmacists, of course, are doing the same thing that Matt talked about and Dr. Rob talked about, but we're not looking at that bottom line of what that med costs.
Sure.
I mean, the patient might need insulin and they have insurance, but they're in the donut hole. Now it's, $1,000. We get the script, we just fill it here. So we're taking care of the poor that need medications.
Okay, you mentioned the donut hole. I knew we were going to get to that sooner or later. Could you just brief executive summary? What is that?
Patients, maybe someone else can jump in on that, but I just know that it's just so high that they cannot afford it. They've already used all the money that was allowed. Is that maybe Matt? Maybe you want to jump in
Yeah,
there?
so,
Yeah.
the
Go
part,
ahead, Matt.
the way the Part D, Medicare Part D plans are designed is that the initial benefit that you're paying for covers from X number of dollars up to X number of dollars. So I think this year, Rob, is it like maybe $3,500 or something like
Are you
that?
talking about the donut hole? I think it's
Yeah.
about 4,000,
About
it's in the
4,000?
4,070
Yeah.
or something like
Yeah.
that.
So once you have, if you have accumulated that much in drug expense under a Part D plan, you go from having what might be a $20 or $35 copay on a brand name drug to all of a sudden you're paying 50% of the price of that drug. And so that's where if a patient hasn't looked at their total finances for the year or maybe has some unexpected medication expenses that they didn't plan for, that the donut hole can be quite a shock where all of a sudden, like you said, it might go from $35 to $135 from one month to the next because of that, where you are. If you spend enough on prescription drugs, you get out of the donut hole and you start paying less again. But it certainly can be a real financial burden to patients when they land there, if they haven't had the expectation that that's where they're going to go in a particular year.
Yeah, it can be a real challenge and roller coaster for patients because there's the 4 stages of Medicare. You have your deductible phase, then the next phase is the initial coverage. Then you have the donut hole, which is what we're talking about, in that catastrophic phase. And patients may start in the deductible paying a bunch because it's all out of pocket, and then kind of level off a little bit during the initial coverage phase where the insurance company or PBM is picking up their portion of it. But then you get into the donut hole and that portion goes up and down, and it's hard to predict, especially if there's medication changes throughout the year to try to improve that person's overall clinical picture. It can become really unpredictable.
Okay, and there we are, PBMs. We knew that was going to come up too. Pharmacy benefit managers, or the middle person. Who wants to just talk briefly about what that is? Who are those people? Senator Grassley here in Iowa brings them up a lot, and not in a good way. Juliet, do you want to talk to us about that a bit?
Sure, I can, give kind of a bird's eye view of a PBM. They're basically these companies that are negotiating with drug companies on behalf of insurance companies and other payers for prescription drug prices. They help determine which drugs a plan will cover and how much those drugs will cost on the plan's so-called formulary or list of drugs that are covered. So they now play a pretty integral role in administering prescription drug benefits for people with private insurance, people with Medicare, people on Medicaid. They really kind of are a central player when it comes to prescription drugs and prescription drug prices in the US today.
So central payer is the term that Juliet uses. We would call them middlemen. And middlemen in every form of the bad term that middlemen are, that take money from every portion of this transaction. So they take rebates from the drug companies, and they sometimes pass those on to the insurance company, or sometimes they don't. They take post fees from us called DIR fees that they take after the fact, after 6-8 months after we processed a prescription. They take dollars away from the community pharmacist, and they also charge sometimes the plans that they're supposedly working for more than they've agreed to charge them, because they'll pay us $10 for a prescription and they'll charge the plan $40 for that prescription. And so they started off as claims processors, just to handle electronic processing to process prescription drug claims. But they've become this giant in the middle of the system that peels money off in many different ways without providing much value. And that's what gets Senator Grassley's ire up. And it certainly gets the ire up of community pharmacists who are at the very blunt end of that stick.
You mean like you?
Like me.
Yeah. To be clear. So
Yeah.
when I go to get a prescription, who actually set the price on that? Are we talking about lots of people set prices on these, starting with the pharmaceutical maker? And
well, it really is the PBM that's very central to the great majority of claims that go through the US healthcare system, because they are the ones that are supposedly negotiating on all these different fronts. But the way they negotiate with us is, here's a contract, take it or leave it. You accept the payment for this, or here's a contract, we'll decide on the day that you process the prescription how much we're going to pay you. But there's 3 of these PBMs that control 90% of the market in the US. And so they make the decision as to how much rebate they can get out of the drug company. And so really, when we talk about the price of prescription drugs, PBMs are central to the fact that drugs in the US have gone up astronomically, because they are pulling these rebates out of the system that have really nothing to do with providing the care to the patients that we're trying to serve.
I think
Andrea,
And I would just,
yeah, Andrea, I saw you nodding your head. You want to go first? Sorry.
yeah, sorry. Thank you. I would just kind of piggyback on what Matt was saying is, that the PBMs do set those prices, and there's several different ways they can set prices, but a common way that they set prices is through a MAC price. It's a maximum allowable cost. And those prices can change every couple weeks. So it's always, it's never a set price that you're seeing. It's really whatever day of the week it is, you need to look up and see what the price is, because it could change the next week and it could have been different from the last week. So I think that is really part of not just the issue that we have in Iowa with oversight of PBMs, but it's a national issue, and trying to understand how prices are set and why we are seeing the costs continually going up, in addition to the other information that Matt mentioned.
Yeah, it's really really challenging because of that market share that they have, but also what they do with that market share. We talked a little bit about from the pharmacy side, but when we're thinking about their negotiation side, if you have 2 very necessary medications that are trying to compete for formulary placement, those PBMs have a lot of clout in making us a certain pharmaceutical drug manufacturer give them a certain rebate price, but there's also a pressure to have that pharmaceutical manufacturer raise the price in order to get a better dollar amount rebate from said company. So the end part of that is that those rebates aren't always passed through down to the patient level and helping people with their pocketbooks. So that's where we really see huge challenges with the just misuse of the power that they have.
I don't think this conversation will be complete, though, unless we bring in the pharmaceutical companies themselves.
Right.
I mean, they are really responsible for setting a list price of a medication that they're bringing to market. It's not the PBM's decision as to what that initial list price will be. So, when we're talking about high drug prices and drug prices increasing from one year to the next, drug companies themselves have, I think, the upper hand when it comes to new products coming to market and the prices that they charge. Certainly, they're involved in negotiating rebates with drug companies, and I think there is a tendency for the list prices to increase because the value of the rebates are also increasing. So the pharmaceutical companies sort of want to maintain their revenue. And if they're giving steeper rebates, they've got to raise prices in order to compensate for that. But they do have a lot of power when it comes to drug pricing decisions. And so I think it's important to acknowledge that as well.
Okay, so before we get too far afield, and I want to remind people watching, if you have any questions, you have any comments, please put them into the chat portion so they can work their way through. So talking about the cost of drugs, and I have to tell you, in a previous job, I used to cover a very large pharmaceutical company you've all heard of. So I have some understanding of this, but drug manufacturers raise their list prices. I read somewhere about 5% a year, they say. And, they have to pay for research. They have to pay for the things that don't become these big blockbuster drugs. I mean, don't they pay for some of this? I know there was this stuff about Mylan raising the price on EpiPens, and we all remember Gilead Science on the hepatitis drug, and they raised those prices. And these things happen, but are they really exaggerating about the costs of all of this? I mean, don't they have to spend a lot of money to make some money to keep those big factories running, to produce these things and test these things and do throughput? Is that not true? Are we picking on them unnecessarily?
No, they need to, they need to make a profit like any other company. But per, Juliet's comment, the way that they go about pricing a drug and the way that they go about raising the price of that drug is certainly way outside the average. If you look at, markets across the United States and the ability to raise prices, the pharmaceutical companies have had a very free rein to do as they wish, because the biggest customer of their products, biggest payer of their products, is the federal government. I mean, between federal and state governments, they're buying, somewhere in the order of 68 or 72% of healthcare that's done in this country. So if you're that big of a customer, you should be able to, sometimes use your buying power to get a price that makes sense to you as the buyer. And I think that, yes, there's R&D that has to be done, but there's also, if anybody, about the only thing I watch on TV is sporting events, but they certainly spend a lot of money on marketing.
I think the other thing I would add to that is, it's one thing to sort of set an initial price that's high that, may be designed to sort of recoup the millions/billions of dollars that are invested in research and development. But it's another thing to, continually raise the price of a product from one year to the next. That is the exact same drug that it was last year, but it's just 5 or 10% more expensive. Like if you look at, an iPhone that's 10 years old, you're not going to pay, twice as much today as you did 10 years ago. That just doesn't make any sense. It doesn't really happen in other marketplaces for other types of products, but it does for prescription drugs. And I think that's what really, insulin is kind of the perfect example of, a drug that it's kind of the same drug, but it's so much more expensive. The EpiPen, another example. So I think that's what, kind of causes a lot of outrage, frankly, among patients when they see these prescription drug prices increase from one year to the next for the exact same product. It just doesn't make a lot of sense to people.
Yeah, I think that the lack of transparency in the system of how medications are priced and how they're paid for just allows these price gougings and these price spikes to happen. I think that's a big part of it. And that is the world that PBMs want to live in. They have no interest in having Andrea have anything to do with their business models. And we are very happy to have Andrea in Iowa to show them that we're going to play business fair in Iowa. And hopefully we can make a little more progress than we made in the legislature last year with that, and give her division the power to regulate these companies, because I still, I would not certainly not give the pharma a free pass, Juliet, but I think that PBMs are much more in the driver's seat of causing an increase in prices and and taking dollars out of the healthcare system that could be used elsewhere, that where they provide very little value and they take a big chunk of money out of the system.
And thank you, Matt. And I appreciate your comments there. And certainly the legislature last year did amend the existing PBM law, and it become effective this July. We are, and the goal of the new law was really to give the insurance division more authority to have oversight of the PBMs. And we are in the process of drafting rules to help provide that enhanced oversight. We've met with several stakeholders, as I know you're aware, and we've met with the Iowa Pharmacy Association, PBM groups, PCMA. We're really trying to reach out to all the entities that have an interest in the PBM law, but we are in the process, as I said, of drafting rules. So I want to encourage everyone listening to be looking out for those rules, and we want to hear public comment on this. Those comments will be important not only to the insurance division, but also to the legislature to hear, just from what you think is needed and what's important to you for PBM oversight. So.
Yeah, I know, Juliet, I promised we would talk about the Inflation Reduction Act, and we will do that. But we've got a question here, and I don't know if there's an easy answer to this. Why have the cost of once so-called cheap, inexpensive generic drug prices risen so dramatically? Is there an answer to that?
Yeah, it really has been it's multifactorial, like most everything else involved in this conversation, Michael, but a lot of that has been the result of a company ending up in, being able to corner the market on the raw materials to make that drug for the whole world. And so when one company is able to come up with what they need to, and nobody else can play in that market for a while, that's when we've seen the biggest spike in generic drugs. I think that happens. It's happened in different parts of the world. It's, China has been one of the ones that has done that with particular drugs, but it's happened in other countries also. And there's been American companies that have been behind that. But it's basically, if they can corner the market on the raw materials you need to make it, they can set the price, and they do it in a way when, if there's nothing to control that price, they've taken it, to the moon. And it typically, it doesn't last that long. Someone ends up being able to do an end around and get through it. But certainly we've seen it with a handful of medications that were very inexpensive 10 years ago that are $100, $200 a month now for a patient or either to the patient's insurance company that, were 25 before. And it's sort of a market economics, but I guess that a lot of people might think that when you're dealing with people's health that you shouldn't be a complete robber baron and think you can just corner a market and do whatever you want with it. But that's what's happened.
Well, I know a lot of big pharmaceutical companies, I know Pfizer in particular, has been very deliberate in protecting its patented, copyrighted brands. And when they see another company coming along wanting to make it, an over-the-counter, make it generic, that they have fought those. And I'm not saying it was only Pfizer, but others have done that too, because they're trying to protect their corner, right? That's how they make money, to do research on others. I know it sounds like I'm an apologist for big pharma, and I don't mean it to sound that way, but that's the argument that I heard for years and years and years, that, well, we need to do this, or we can't make we can't spend money on the things that not that many people need, but you need, or your child needs.
Yeah. And to Juliet's point, they know that they have 16 years from the time they get the patent in the US to have that exclusive product. And but there's a lot of pharma companies that have found a way to take that 16-year protection and turn it into 21 or 22. And with that 5% or 9% price increase every year as they go through the process of paying their lawyers to keep them in that position. I think it's very underhanded when you think about, here's the rules of the game that they knew about when they just, developed the drug, but they find legal ways to work the system to maximize that. And there's the documented expense to the system of extending those patents is tremendous number of dollars that are paid out. So.
Right,
Rob,
and it's
you're
not just the patent
ahead.
extension. Sorry, it's not just the patent extensions. It's the multiple patents on a single product, these so-called patent thickets, where one drug doesn't just have one patent; it has 20 or 30 or 50 patents that are related to the drug, but maybe also if there's a device like a pump or a needle or something, there are patents around the devices as well. So it then becomes very difficult for a generic manufacturer to come along and copy that product because there are so many patents surrounding it, not just on the original product itself.
Don't they sometimes say we've reformulated, like the albuterol inhalers? Oh my goodness, those were dirt cheap in the 60s and the 70s. And now they're so expensive and so many patients have to have those albuterol rescue inhalers, but they reformulated them. It's just the consumer, it's just not fair.
Darlene, you saying you don't believe it by those air quotes with your
No, I mean, in the Cobenamid and the Bactrim DS, all those less expensive drugs that we really like to use, the generic drugs, it's just heartbreaking to try to keep all the patients in need medication, and then the price just continues to go up for us to buy the stock bottles of those medications.
Yeah, I mean, I think that's the concern when a product is nearing the patent expiration date. Some drug companies may pull that product off the market entirely and introduce a new, so-called reformulated version that then has another, 15, 20-year patent life and is more expensive than the version that's pulled from the market. So it creates obviously, incredible financial difficulties for patients who needed the old medication and don't have any choice but to switch to the newer, more expensive drug.
Michael, I think
Darlene, go ahead, Matt. Sorry.
One of the other things I think that kind of skews the conversation about the price of prescription drugs is the way that they have been siloed in the system. When you think about prescription drugs are really the cornerstone of what we use to treat chronic conditions. Now, maybe we should be using diet and exercise way before we start using prescription drugs, but fact of the matter is they are, the kind of the baseline of therapy to keep people healthy in the long term. But we pay for them outside of the total cost of healthcare in so many ways. Medicare Part D is, everything, all the PBMs and the insurance companies that are involved in that. The great majority of them are being incentivized to concentrate on the drug part and not concentrate on the whole patient and total healthcare costs. And so when you look at drug pricing, it's up to about 13 or 14% of the total healthcare dollars are prescription drugs. They're felt a lot more on the consumer level and the patient level because of copays and things. But I think one of the things we could do to actually get a better value from the medications is if we really looked at the patient as a whole, and as Rob and I started off to talk about, true team-based care in the system, where we're taking the skills of the pharmacist along with the skills of the nurses and the prescribers and physicians who are involved in that patient's care and working together closely. That's really the key, I think, to not only impacting care in the best way, having the best outcomes for patients, but also saving dollars that are being wasted in the system because we're not coordinated enough.
I think, chronic drug therapy management, that's exactly what you're talking about, Matt. And I think a lot of times in the public space, the pharmacy's viewed from the, product dispensing standpoint, but all pharmacists that are graduating from pharmacy school and completing residencies are very well trained in chronic drug therapy management, not only making sure that that drug is safe for the person, but that is progressing that person on the right doses toward that ultimate therapeutic outcome that's going to prevent those expensive hospital visits, which are going to reduce the total cost of care. So like Matt's saying, if we start to think about the drug spend as a part of the total cost of care, but add in that chronic drug therapy management portion, we've already seen in Iowa how much money that can save a payer with our Wellmark value-based pharmacy program.
Do you want to talk a little bit about that pharmacy program, Rob?
Yeah, Matt, you were in more of the meetings, I'd say, than I was. So I'll let you speak a little bit to that.
Yeah, Wellmark utilized a network of about 75 pharmacies across the state and incentivized pharmacists to focus on patients with chronic conditions and what we could do to help not only keep them on the medications they should be on, keeping them adherent to their medications, helping them develop strategies to say, I could avoid an ER visit and avoid a hospitalization if I follow this regimen. And it came down to team-based care, working with prescribers to get people on drugs that work for them and drugs that they could adhere to and stay with. But we showed in a 1 year time, there was about $15 million worth of savings that to the total cost of care. Even though we may have spent a little more on prescription drugs, the total cost of care went down. And it's really all about involving pharmacists very actively in the team to help patients have the best outcomes they can have.
So on the ground, from a practice standpoint, I mean, some of the things that we were doing were we would be taking blood pressures in the pharmacy, or we'd be talking and coordinating with their providers about, what their most recent A1C levels are, recognizing that, okay, the A1C was here, not at goal before, it's here now, and nothing was done differently between there or a conversation we had about their diet. Well, now let's make sure that we're doing something to move the needle forward from the diabetes standpoint. From asthma standpoint or COPD, the person may have only been on a rescue inhaler when in fact it may be more appropriate for them to be on a maintenance inhaler and only have to use that rescue inhaler as needed. And ultimately, we started seeing decreased hospital visits because people aren't having exacerbations. And it was just kind of that, make sure people adhere it, try to move their therapy forward. And we recognized very great savings in the total cost of care, even though by helping people be more adherent, it may have been that the actual drug spend may have went up.
So Darlene, so we're talking about diabetes and we're talking about asthma. What are the particular kinds of drugs that you see that you need or that you're giving out at the community health free clinic? Are there more of some kinds of things than other kinds of things, I assume?
Certainly insulin is one of our bigger factors, and the inhalers. I want to plug in for the SafeNet that that the state of Iowa has, where patients can return, or pharmacies or nursing homes can return their medications to SafeNet. And then we can apply for those medications. And just this last week, we got 3 months of retail meds for $537,000 that we can hand out to our patients. So that's a big way that we could get our medications back if the pharmacists or nursing homes can return those to SafeNet so that we get them and redistribute those medications safely. So that's just, and then we have the prescription assistant program. That's a huge help to us with our patients so that we can apply for those medications. We work on that a lot, and then we purchase the stock medications bottles that we can hand out to patients. But insulin, if we could buy the lesser expensive ones, but the doctors don't use those. The doctors want to use the Cadillac. They have better outcomes with that. So the Novolins, the N and the R that are so less expensive, you're not going to get any of the providers wanting to use those. They want to use the Tresiba and the Victoza and the Farxiga, all the better outcome patient prescription drugs.
Okay, so we've concluded it all costs, everything costs a lot for the variety of reasons. So Juliet, you and I were talking about this the other day. I admit I was in a grocery store parking lot at the time, but we were talking about the giant Inflation Reduction Act that passed in August. And in that, as part of the many things of that, U.S. Health and Human Services was empowered to negotiate prices for certain drugs covered under parts of Medicaid. Could you maybe talk us through that and give us sort of an overview of what all that, what's covered? What are we talking about here? What does that mean?
Yeah, sure. So the Inflation Reduction Act was signed by President Biden in August. It is a pretty monumental, I think, set of changes with regard to how Medicare pays for prescription drugs and will provide significant out-of-pocket cost savings for people on Medicare enrolled in Part D plans who need expensive medications. So as you said, Michael, the IRA allows or really requires the Secretary of the Department of Health and Human Services to negotiate drug prices with drug companies for drugs covered under Medicare Part D and Part B. The Part B drugs are those that are administered by physicians, and Part D drugs are the ones you get from your local pharmacy. That is groundbreaking, really, because prior to the Inflation Reduction Act, the federal government was explicitly prohibited from negotiating drug prices. That was left up to the private plans and PBMs to do those price negotiations. So we're not talking about the universe of drugs that Medicare covers. We're only talking about a relatively small subset of high-cost drugs that have been on the market for a number of years. The first year that negotiated drug prices will be available will be in 2026, and there will be 10 Part D covered drugs that will have negotiated prices available that year. Another key provision in the Inflation Reduction Act is that drug companies will have to pay a rebate to the federal government if the prices for their drugs increase faster than the rate of inflation. That is obviously designed to help keep drug price growth in check. And I think that's one of the widely recognized problems with prescription drugs in the US. And a third key provision is right now, under Medicare's Part D benefit, there is no annual cap on out-of-pocket drug spending. So as was described earlier very nicely, there are these different phases of the Part D benefit, and there is catastrophic coverage. But when a person gets to that phase of the benefit, they still have to pay 5% coinsurance. And that 5% maybe doesn't sound like a lot of money, but when we're talking about a drug that costs $10,000 a month, you know, you do the math and you end up with a significant out-of-pocket cost burden for patients, and that lasts the entire year and there's no cap. The law will cap out-of-pocket drug spending under Part D starting in 2024. That 5% coinsurance goes away, and then in 2025 there will be a hard cap of $2,000 on out-of-pocket drug spending under Part D. So those are kind of the three key provisions. There are other important changes, like, for example, you know, we've been talking about insulin. Starting next year, insulin prices, well, not prices, but the monthly out-of-pocket cost that Medicare Part D enrollees pay will be capped at $35 per insulin product. And all adult vaccines that are covered under Part D, like the vaccine for shingles, will be available for free. So there are some really important changes for Medicare beneficiaries who have struggled for years to afford their medications. And these changes, the inflation rebate provision is also, you know, it's hoped that it will also help keep drug prices in check for people outside of Medicare, although it won't necessarily directly benefit them the same way that it will people with Medicare.
So this is a good thing, right? Andrea, this is a good thing, right?
Yes,
From your
yes.
perspective?
Juliet gave a very good overview of the changes, and they are significant, as she said, and kind of rolling out over time. So I think people are are wanting to know how well the law will work, but I think it's too early to tell. But we'll kind of wait and see what happens. But yeah, the impacts that this has for Part D and Part B drug pricing is substantial. And the one thing I would just add, and you may have touched on this, Juliet, so I apologize if I'm repeating, but I also recall that there's a rule, I think it's effective in 2024, that prohibits premiums from being increased by more than 6% for most of the Part D plans, but in 2024, a person's premiums can't be increased more than 6% from year to year. So hopefully all of these different provisions really make an impact to drug pricing for at least Medicare beneficiaries.
Yeah,
And-
that's an important point to mention. You know, and the Congressional Budget Office, which is Congress's sort of official scorekeeper, has estimated that these provisions will save the federal government over $200 billion over 10 years. So we are talking about a significant amount of savings to the federal government, the Medicare program, which translates into, you know, savings for taxpayers, but also real out-of-pocket cost relief, again, especially for people on Medicare who need high-cost medications. And maybe you're healthy today and you don't need high cost medications, but, you know, I think we're all a scary diagnosis away from needing expensive medical care and needing expensive prescription drugs. And the provisions in the law are designed to help, you know, alleviate the affordability challenges that people are facing.
And,
thing
and
I
Andrew,
like, go ahead.
Andrea, you mentioned, so for those of us who don't know this, Medicare D is for drugs, B is doctor visits.
Yeah, and hospitalizations
Outpatient.
and more, excuse me, outpatient, I guess A's hospitalizations, but the B's the outpatient drugs.
A lot of letters. And
Yeah.
Julia, you mentioned 10 drugs that will be covered. What can you give us some examples? You
Yeah.
have to give us all 10, but what are we
Well,
talking about?
it's difficult to give specific examples because the selection of the drugs for negotiation will happen next year. In September of 2023, HHS will publish the list of 10 drugs that are going to be selected for negotiation for that first year in 2026. But we're generally talking about drugs that have been on the market for a long time, at least 9 years for these so-called small molecule drugs and 13 years for biologicals. So they've been on the market for a while and they have no generic competition. So this is a case where, you know, the market really isn't working the way that I think it was hoped, that, you know, brand drugs would come into the market, they'd be around for a few years, companies that make them would get a lot of money, and then generic competition would enter and prices would fall. But the negotiation provision is designed to target those drugs where there is no generic competition, where the prices remained relatively high, and the Medicare program, the Secretary of the Department of Health and Human Services will intervene to negotiate a lower price for those products.
So Matt, this is a good thing, right? This is what Senator Grassley's been talking about, and Maria Cantwell, that it keeps an eye on PMBs and it tries to get some control over prices. This will be good. This is good for your patients, your customers, right?
It certainly has the potential to be good. I think the devil in the details, Michael, is do the PBMs find another loophole that allows them to access these dollars into their own pockets, or do they, you know, the PBMs have gotten this vertical integration where they own insurance companies, PBMs, and pharmacies. So CVS owns pharmacies, they own CVS Caremark, the PBM, and now they own Aetna or somebody else, I think.
Yes.
So that's, you know, when you're vertically integrated like that, you can pick and choose kind of where you move dollars, and they don't have a lot of stake in saying that there ought to be access to care and access to services in rural Iowa. You know, they're fine with having you be forced to use their mail order company if you don't have a pharmacy in your neighborhood anymore. But as you drive down prices, if you don't take care of the infrastructure of community pharmacies across the country, there's a certain risk there that patients aren't going to be able to access care. And so in the big picture, I think controlling total cost, out-of-pocket costs for patients is certainly very positive. And bringing drug manufacturers to the table to negotiate, I think, is also very positive. I think you have to look at the big picture of access to care and tread that carefully as you set these programs up. And a lot of it comes down to giving insurance divisions the opportunity to say, this has to be a level playing field as the way that these contracts are done. The fact that Caremark wants to send out a contract and make it look good for CVS, but not good for Greenwood Pharmacy or Osterhaus Pharmacy shouldn't be the way the game is played. But that's what we're dealing with right now. And that's got to change, because the bottom line is most patients don't want to use their mailbox as their pharmacist. They want a pharmacist that they can trust and talk to, that can help them navigate the healthcare system and to optimize their drug therapy. And that's what we're here for. And we'd like to stick around.
Rob, I see you nodding your head, and I want to get to you in a second, but Matt, while you have the floor, so Senator Cantwell, who's the chairwoman of the Committee of Commerce, Science, Transportation, I think, and Senator Grassley, both talk a lot about spread pricing. What is that? Can you give us just a definition?
So the spread pricing is when the PBM has contracted to say that the price they're going to pay me is $21 for this medication, for the service I provide to get this medication to the patient. So they pay me the $21, but then they charge the Medicaid program, or they charge the federal government $42 because they do it behind smoke and mirrors. And that's the spread. That extra $21 that they took out of the system that's their profitability, and it's taking away resources that could be used to, help fund Darlene's clinic, or to put an extra nurse practitioner in a practice to be able to help a rural health access to care for rural patients. And they've done it, and they found a way to, like I said, take money out of the system in every way possible. And that's one of the things. There's been several lawsuits against these PBMs that are supposedly, being a central portion to how medications get to Medicaid patients. Medicaid managed care organizations around the country are, there's been a lawsuit. They $220 million in a single year in the state of Ohio that they overcharged the state. And these are the same managed care organizations that are doing business in Iowa and other states. And the number of lawsuits just keep going up because finally some places are pulling away the curtain and looking at some of their business practices. But that's spread pricing, and it's only good for one player, and it's the PBM.
Okay, Rob, we've only got a couple minutes left. Anything you want to add to that?
Yeah, well, it's just on that note, it's as simple as saying the pharmacist saying, hey, I'm getting charged this much. And then the ultimate payer is like, well, they're charging me way more than they're saying they're paying you, and that without a real concrete justification on the difference in the price. But when we were talking about the Inflation Reduction Act, a couple of things as far as when Matt was saying, where are they going to go next? I was wondering, I didn't see it in the bill, but were there any provisions on limitations on changes in deductible? Because we've seen the deductible jump up a lot this year based off what it was last year. So I'd be curious on if they're able to shift risk that way. And then also
we've
the
only got
CMS
about
rule
30
on
seconds left here, Rob. So
DRFs.
if you want an answer to that. Okay, Juliet, do you know the answer to that?
No limits on changes to the deductible. So that will likely, continue to increase with the rate of growth in per capita costs.
Okay, so I'm sorry to cut you off there, Rob, but I didn't.
Nope,
As we said, starting, this is a big topic. And we've chipped away at some of it. So I want to thank University of Iowa Hospitals and Clinics for sponsoring the healthcare track. I want to thank our room host. I want to thank our panelists. I want to thank you watching. Remember, there are many, many more panels and speakers across a variety of tracks in this year's Iowa IDS conference. And that's today, and there are more tomorrow. So I want to thank you all, and please keep watching. Thank you, panelists. Have a nice day.